Okay, I think we'll get started. I'd like to welcome you all to this edition of what is really a series from the Johns Hopkins Center for Chiari Malformation. It's being produced and presented and brought to you also by the Chiari Foundation, the Chiari and Syringomyelia Foundation, as part of their educational series. We have a wonderful session here planned tonight because we have an expert in spinal cord injury. As we all know, Chiari malformation, we are always considering injury to the superior part of the spinal cord and the injury that occurs with syrinx. And we have today Dr. Nicholas Theodore, who is really an internationally known expert in spine surgery generally, but also does very basic and physiological work with spinal cord injury, also pioneers and proposes new methods of treatment, which I think we're going to be hearing about, and also I think most recently has pioneered things like robotic surgery. So he's really run the gamut from sciences and physiology to technology and robotics. I think you're doing a case right now, robotically. Good. So we'd like to welcome Nicholas Theodore to talk about spinal cord injury, generally speaking. We've given you free rein.
All right. Thanks. Thank you very much, Mark. Well, it's a great pleasure to be here this evening and see so many familiar faces in the audience and such an enormous turnout. I'm deeply appreciative for everybody that we didn't have snow today in Baltimore, which is a good thing. So I think that has everything to do with the turnout. So what I'm going to talk about is not 100% related to Chiari, but it is related to Chiari. And I'm going to talk about some research I've been doing and some thoughts I have on pathophysiology of spinal cord. Because when we talk about Chiari malformation and we talk about Syringomyelia, both of those, the neurologic effects have to do with compression of the brainstem, compression of the spinal cord, expansion of the spinal cord, and those neural tissues are affected. And I think that having a better understanding of exactly what is happening and what is going on in a broad sense gives us at least a glimpse into part of the pathophysiology of what happens in disease processes like Chiari and Syringomyelia in general. Long list of people that have worked with me along the way, and my disclosures. And I got interested in part of a lot of this has to do with not just the spinal cord itself, but also the blood supply to the spinal cord. So when people have dysfunction, and Chiari is one of those, when we have compression of neural tissues, when the tonsils descend and we have compression of the brainstem, it's not just a pure compression phenomenon, but there's also changes in blood flow regionally to that area. And that probably has something to do with the disease process. When we look back historically, this has been sort of an interesting era. These two characters at the turn of the century, in the 1900s, really spent a lot of time, Kaji and Adamkiewicz, looking at the blood supply to the spinal cord. And that becomes very important to us when we think about spinal cord injury, and we also think about disease processes, again, like Chiari and Syringomyelia. At the end of the day, this carried on through England, it carried on through here at Johns Hopkins, and ultimately we have a very interesting history here at Hopkins dating back over 100 years in spinal surgery and treating patients with a whole variety of problems. And when you look historically, I think, and Chiari is a perfect example of how our knowledge and understanding has changed even over the past 20 years. We have a completely different understanding. When I started residency, there were a couple of prevailing theories. This is what's going on and this is what's happening. And the reality is most of that was wrong. And we're learning every day about different things that might be causative. Now we're looking in the realm of genetics and other things that may be predisposing patients. So it really has become an exciting time. I'm going to talk about two things that again, I think sort of in a big way are sort of part and parcel of this. One of them is stretch of the spinal cord, and the second one is really some basic physiology of cerebrospinal fluid. Both of those, again, are relevant in a way. I got interested in this a few years ago. I'm going to talk about something that's a little bit off the beaten track, which is posterior vertebral column subtraction osteotomy. It's a mouthful, but I'm going to explain it to you here in a minute. When we look at tethered cord, and when patients have tethered cord along that spectrum, we always look to see, do they have a Chiari? Are there's an interrelation between tethered cord, Chiari malformation, etc. And ultimately, when you have a patient with tethered cord, the problem is simply this. You've got the brain, you've got the spinal cord, and it's under stretch. So think about having a rubber band around 11 building blocks or 12 building blocks, and that rubber band is stretched. In this case, when you have a tethered cord, the spinal cord is stretched as well. So you've got this tension, this constant tension here. This is two gentlemen pulling on that spinal cord, and ultimately that dysfunction ensues. And that presents in a number of different ways. This gentleman here, Alf Brieg, anybody know who heard of that name before? So you might be, oh, all right, more than one, I like that. So Alf Brieg was a Swedish neurosurgeon, became very interested in the pathophysiology of what happens to nervous tissue under stretch. And interestingly, he wrote a book and wrote a lot of articles. This bottom line here, it says Alf Brieg is who won the Nobel Prize. This is from a chiropractic website. Did he win the Nobel Prize? No. But the chiropractors think he did, because interestingly enough, chiropractors have adopted a lot of his teachings in having to do with stretch of neural tissue and how the body adapts to that situation. So he did a lot of beautiful studies, and these are silver stain here of actual spinal cord. So look what happens when you flex your neck. When you flex your neck, those fibers are tightly aligned and they're under stretch. So this is in a normal cadaveric specimen. Just putting your head down to read a book, your spinal cord is under stretch. That stretch may be in a different situation depending if you have a Chiari, if you have instability at the craniocervical junction. So we know that in a normal range of motion of the neck, the spinal cord undergoes some stretch. When you look up at the stars or look up at the ceiling, that spinal cord is relaxed. Then he looked at this. Also, what happens if you have some compressive pathology? Let's say you have a osteophyte or a disc herniation. Again, when you flex your neck, look how taut those fibers are. Those fibers are stretched over that in this case is metallic BB, and you've got increased compression, which is why in a lot of patients, what happens? We see them in clinic. They put their head down. They have increased neurologic symptoms because they're stretching the spinal cord. And we see that in Chiari patients sometimes as well. And in extension, again, that gets relaxed. So that was looked in sort of a very interesting animal model. This is the Japanese game fowl. And it turns out that after doing a C4-5 laminectomy in the game fowl, you go from a normal neck to this kyphotic neck, and this happens over the course of just several weeks. So again, just by doing a laminectomy, we can make this bird turn into a kyphotic angulation. And there's no motor paralysis, but look what happens to the spinal cord. On the left, you see the control tissue. So you see small blood vessels permeating the spinal cord. That's normal. Well, those are the small endarterioles come from the anterior spinal artery to perfuse the spinal cord. Look what happens when you have a kyphotic bird. So you take this away and you've got this under stretch. So I'd argue that whether it's stretch from Syringomyelia, potentially, compression from Chiari, we're losing volume of the spinal cord. A lot of times we'll do these procedures, patients who have myelopathy, and what do we see in the MRI after? We see myelomalacia, or we see an area of tissue volume loss. And I would argue that's because we've lost blood supply, and that is not sustainable tissue. So it's a very interesting control model. When you look here again, this is looking at demyelination, so normal fibers, heavily myelinated, beautiful fibers of the spinal cord. And again, at the bottom, what you see in these kyphotic animals, and these are animals where the spinal cord gets stretched. So we're able to induce a myelopathy, and what happens is that we lose myelin. What happens when we lose myelin? Well, we know in MS what happens, but in non-MS, in a patient who has myelopathy, we have neurologic dysfunction, and that's what happens. So tethered cord, in its general sense, is really this constellation of neurological signs and symptoms related to this longitudinal traction. And there's a lot of causes: thickened phylum, lipomyelomeningocele, there's split cord malformation, and there's a whole variety of things that can lead to this tethered cord. The typical symptoms, we know that patients can present with low back pain, sensory loss, motor loss, sexual dysfunction, urinary incontinence. The presentation in children is a little bit different than in adults. So if a child presents certainly with tethered cord, sometimes we'll see this tuft of hair, we can see a clubbed foot, we may see an open defect. And the reality is that this is slightly different pathology. And I was thinking that a lot of these patients will have surgery for tethered cord as a child, and then they do fine for a period of time. And then for some reason or another, something sets them off, and they get worse. And and they start developing severe back pain, etc. And I was wondering, trying to figure out why that would happen. Why we've done a detethering operation on you as a child? Is it because you're growing? Is there more stretch? But as you talk to these patients, it can be anything. I talked to a young woman a few years ago who slipped on ice, fell, and had a very hard fall. Another woman who was in a car accident. Little things can set people over the edge when the spinal cord is under stretch for a prolonged period of time. Shoki Yamada, God rest his soul, passed away, was the chairman at Loma Linda for years, did some very elegant studies showing what exactly happens in the animal model when you stretch the spinal cord. So we saw Alf Briggs showed us the beautiful figures, but from an electrophysiologic standpoint, when you stretch the spinal cord, guess what happens? All the electrical signals drop out, and we get a loss of electrical function. The conductivity of the spinal cord as a conduit, as a connection between the brain and the rest of our body is lost. And that happens with stretch. And as you stretch gently on the spinal cord, it happens. When you release it, it goes away. Think about Syringomyelia. What's happening? We have an expansile cavity within the spinal cord, which again is going to be causing neurologic dysfunction. A lot of these patients with Chiari or severe Syringomyelia, when we do electrophysiologic monitoring during surgery, they don't have any discernible monitoring because again, there's probably damage that's being done. I wrote about this a number of years ago, just looking at the literature, and there's a lot of things that happen. So when you have a spinal cord that's under stretch, in addition to this electrical phenomenon, neurologic things, on a cellular level, things are happening as well. You have a reduction in blood supply, as I showed you what happens with the blood vessels. We have impaired oxidative metabolism. You get hypoxia, and things don't bode well. So what do we have for these patients? Traditionally, we have spinal cord detethering. In the upper right-hand corner, you see me a number of years ago cutting these little adhesions and trying to loosen things up. And the reality is, after spending hours and hours and hours doing this, you don't really feel like we've done anything, at least I don't. Patients wake up, a lot of times they'll do well for a short period of time, but if you look at how they do over a long period of time, they'll do well for a while, they may even improve, then they start to decline again. And why is that? So as we're operating at the base of their spinal cord, at the end of their neuroaxis, they realize that we can free all this up, but the spinal cord's still under stretch. No matter what you do, it doesn't really foreshorten, and the whole construct seems to be under stretch. So it wasn't me, I wish I could claim this, but Kokobun in Japan said, well, since the spinal cord's under stretch, why don't we do something a little more radical? What would that be? Why don't we take a vertebral body out and shorten the patient? Why don't we take a patient, make them a little shorter? So again, if you go back to my building block analogy where we have 12 building blocks and a spinal cord, which is a rubber band to stretch, you can work at the bottom all you want, but if that doesn't shorten the cord, maybe taking out a building block, that definitely does the trick, right? Because if I take a building block out, that rubber band is under less stretch. So the whole concept of shortening procedure or vertebral column osteotomy was hatched by Kokobun about 20 years ago. When you look at this, again, as you look at the bottom of this, patients had multiple surgeries, CSF leak, scarring. It's an unsavory task to do this, and there are experts who do this on a daily basis. My question was, and what I wanted to try to examine, and we'll be looking at this for quite some time, is whether or not is there something else that we can do globally to release that tension without having to go back in. So back in '95, Kokobun showed basically an osteotomy of T12. Why T12? Well, it's a flat segment of the spine. It's a vertebral body that we can take out below the dentate ligaments so that when we take it out and shorten the spine, we're actually going to shorten the spine. If you take out something higher in their dentate ligaments, you're not necessarily going to get the same effect as if you do T12. When you take out a lower lumbar region, then those are much more difficult to remove. T12 is sort of the index site. Why is that good? Well, there's no direct manipulation of the neuraxis. I'm not opening the dura. I'm not going through scar tissue. I'm not cutting these adhesions. What I'm doing is literally taking pressure away from the spinal cord indirectly by literally taking the vertebral body out and shortening the spinal column. So we don't have CSF leaks with this, and it's potentially more durable. You know, I think that when you looked at some of the original series, there was a fairly significant improvement. It got some excitement, and it sort of went to the wayside because really it's a large operation, and it's difficult in some cases to talk to patients about this. When you look at Kokobun's series, he had 8 patients. This is back from 2011, and essentially had fairly good results. The follow-up wasn't very long. The shortening was about 21 millimeters, and he had really all of his patients had some sort of improvement in their symptoms. The durability of the outcomes is sort of questionable again because the follow-up wasn't. He had a several-year follow-up in some patients, a lot shorter in others, and these are difficult patients because a lot of things are happening at once. Okay, like Chiari and Syringomyelia, the tethered cord patients have a constellation of symptoms that can be motor, sensory, bowel and bladder, sexual dysfunction, etc. A lot of things can happen, and it's very hard in one domain to say, oh, everybody got better in motor or sensory, etc. And so following these patients can be difficult. So we went to the lab and said, okay, well, what exactly is happening? Is T12 the right level, and can we do better, and is there a way to quantify this? So we took a number of cadaveric specimens. We sort of recreated the operation in the lab. I wanted to see, if this is the fact. Are we actually shortening? As we shorten these patients, are we taking tension away? Is that really what's happening? Because again, this first series Kokoman did, he said, well, makes sense, let's try it. And I said, well, we can do that, or we can just, before we start doing that in patients, we have a little bit better understanding. Even though we know stretch is bad, we know that from Brieg, we know that from Yamada, the reality is that looking at this in the lab was a very powerful exercise for me. Looking at the dentate ligaments, looking at the spinal column, and as we shorten that spinal column, measuring those tensions and figuring out, are we actually taking stretch away from the spinal cord? And this is sort of what things look like. Understand that in the middle of this operation, when the T12 vertebral body is about 80% resected, you're looking at two different people, the top half and the bottom half. So this is an operation that needs to be done with at least 2 qualified surgeons, and it's a hands-on operation because if something slips or moves, you'll paralyze somebody because we're operating at T12. We are operating on the spinal cord. So first and foremost is patient safety. When those patients disconnected and the vertebral body's out, if one of those rods slips, then literally you'll have a spinal cord injury. That's something that we want to avoid, obviously, at all costs. And this is, again, taking out about 20 millimeters and then shortening the vertebral column. So we looked at myelography. We started being able to hang weights on the end of the spinal cord and say, okay, what exactly happens? You hang weights, there's definite tension on the spinal cord, and then what happens is what you think happens. As we take that tension off, that pressure, that pull goes away. And how do we know that? We know that from pressure measurements, but we also know that from, as we look at these reductions, look what's happening to the spinal cord. These are normal cadaveric spines. These are not, we don't have access to spinal cords, to cadavers that have tethered cord, unfortunately. But in this case, what you see is the spinal cord itself begins to be foreshortened, and you see there's a slack in the spinal cord, so it's not its normal strength, So you've got a spinal cord that's under stretch, and as we shorten that vertebral column, you see a little bit of a buckling. The problem with the operation is that, and we've sort of settled on about 25 millimeters as being the number, because after that, what you can get is a buckling or kinking of the spinal cord, and that can cause a problem to anterior spinal artery or to a blood vessel, which could potentially, again, ruin and negate your results. So about 25 millimeters, again, is what we looked at, and again, you start doing more than that, we start getting the problems, but ultimately, about 25 millimeters was an excellent way. So we started doing this prospectively in my former life. I was in Phoenix for 20 years, and the first patients were done there. We looked, first of all, in the literature. There was a few studies done, about 18 patients reported in the world's literature. We felt it to be safe, we felt it to be effective, but we wanted to look at it prospectively and really follow these patients. To date, we've now done 21 patients. Our first patient was done here at Hopkins about 3 weeks ago, who I'm happy to say is doing phenomenally well. This is a young woman who had 5 lumbar spinal detetherings, most recently about 6 months ago. This girl was absolutely in agony, and she described the pain as a knife being stuck in her back. Surgeon talked to her about potentially redetethering her. She said, I just don't know. Every time I do it, I get better for a little bit of time, and it doesn't last long. So I talked to her about vertebral column shortening. She's a very brave young lady. We did the operation, and literally within 24 hours, she came to me, and she was in the ICU after this operation, crying with tears of happiness. That sharp pain, she said she can feel her legs now, which she couldn't feel. That sharp stabbing pain is gone, and noticed a distinct change literally within just a few hours of surgery. That's a very powerful thing. Now, part of it may be a placebo effect. We're obviously going to follow these patients for a long period of time to look at the durability of these outcomes, but it's, I've seen this time and time again. Of the 21 patients, average age of about 37, every one of them had prior surgery before. All of these patients have had detetherings, multiple detetherings. If you ask these patients at the end of the day, what would you rather have done after the spinal column shortening, they would tell you, every single person has said to me, they'd rather have that than another detethering. The part of the detethering, which is a robust operation, which is really the standard of care for this disease process, the problem is that these patients have spinal fluid leaks, they're prone to infections, and it's really, the recovery is not happy. Maybe not so happy with the vertebral column shortening in the short run, but in the longer run, these patients, I think, tend to do better. This is some of the relevant anatomy as we take out the vertebral body, and again, we've got rods on both sides, temporary rods, and then we shorten the patient. And the end result, as you see here, is to sort of get those two pieces to come together. This is what it looks like in surgery. We've got these towers, and it's very complicated. Basically, again, all about keeping things together as we take that vertebral body out. This is an actual surgery here, which I'll be able to fast forward to use image guidance to be able to put the screws in. In our last case, we actually put the screws in utilizing a robot, so it's very interesting. We get to use the latest and greatest technology to do these operations. We're doing a laminectomy here. And ultimately, we get to the point where we're looking at the spinal cord here within its thecal sac, and we put a temporary rod in, because as you start taking that vertebral body out, and that last piece you take out, if there's nothing there, that thing separates and the spinal cord gets stretched. So here we are doing the osteotomies, and at the very end, you can see here what we're doing is now very slowly compressing one side to the next and shortening that patient. And again, you look at all this metal instruments coming out of this patient, an incision about this long, 4 hands, and a little bit of sweat, and as always, great amount of care as we do this. So what do we find in these patients? It's very interesting. When you look preoperatively and postoperatively, you see that the bowstringing of the spinal cord is less, and we started making some measurements, and we found out that ultimately the diameter of the spinal cord increased. So think about this. What happens when you take a piece of licorice and stretch it? It becomes thin, right? Longer and thinner. And I think the same concept applies here. As we took that body out, and you can see these measurements, we did cross-sectional measurements at multiple levels. There's actually an increased diameter of the spinal cord. And I would argue that that's because it's not under stretch anymore. There's really no other way that would be possible. And that's really across the board we saw that. And essentially there's a more favorable position of the spinal cord in addition to that. So I think that when I look at that, I think that's from a radiologic perspective, it's fairly powerful to see that the actual morphology of the spinal cord is changing. And then neurologically, we've had improvement in almost all the patients in their leg pain or back pain, some improvement in motor. But again, remember the problem is with these patients, not everybody has a motor problem. Not everybody has, so everybody's different. But I think by and large, what I will tell you is that as we look at these patients now over the past several years, I think the longevity is very good. We've not gone back and done a redetethering in any of these patients for worsening. So that's one powerful thing that we've gone through right now. So if it didn't work and we had to go back and do a detethering, that would be another story. Complications, we've not had any durotomies or neurologic injuries, thank God. Most of the patients are in the hospital for several days because it is a big operation, and a lot of these patients are debilitated to begin with. No significant perioperative complications. In one patient, we went where we'd fused one level above and one level below, and it was a big guy, bigger than me, and I'm a big guy, had popped the caps off his rods. He was fine. We ended up taking to revise him. We now, really the standard is to fuse 2 levels above and 2 below. And from a motion situation in the spine, that's really not a big deal. So again, the pain outcomes and neurologic outcomes are really similar, but again, we have shorter follow-up. When you look at the tethered cord literature, there are series that go out 25 and 30 years. So we don't have that durability and longevity for this series. But the reality is, I think that this is something that we need to continue to do, at least as an offering. I think the risk profile is such that in the proper hands, and this is not an operation really for the faint of heart, it really shouldn't be done, it really isn't a community operation either. This needs to be done in a larger teaching institution or a larger place because it is a significant operation. But I do think that it is an alternative to tethered cord. The beauty about being at a multidisciplinary center like Johns Hopkins, I talk to the pediatric neurosurgeons, In this case, Marty Grove is my pediatric partner. This was her patient. We had a discussion. We presented all the options to the patient, and were able to sort of in an informed way make decisions about what might be the best treatment for these patients. We don't know, and I can't stand here and tell you today that this is the answer, but I think if you look at the history and the pathophysiology of this disease process, is something we really need to look carefully at. I'll let you pick who had the shortening operation here. So we're going to talk the last thing I want to talk about is spinal cord injury specifically. And when a spinal cord injury occurs, it unleashes a whole host of things, right? So we talk about primary and secondary injury. The primary injury is just the force itself, the impact that the spinal cord sustains, whether it's a car accident, gunshot wound, stabbing, whatever. Then what happens after that is incredibly complicated. So if you look at this diagram here, you see things happen all at different times. You get scar formation, we have ischemia, we have vascular changes, we have demyelination, scar tissue formation, excitotoxicity. There are labs throughout the world that have studied each and every one of these processes. And from a lot of these come out a quote-unquote wonder drug. There'll be a drug that comes out and says, oh, we're going to target demyelination at 30 days, and this is going to make, cure spinal cord injury. The reality is, and as somebody who is not a hardcore basic scientist, but has been enrolled in patients in multiple clinical studies, there isn't going to be one drug for spinal cord injury. It is not, that's very short-sighted. And each lab that works on each one of these processes has something that might work in rats. My take-home message here is that what's good for the rat is not necessarily good for the human. The reality is that thinking that there's going to be one treatment for spinal cord injury is short-sighted. Might there be a cocktail delivered over a period of time? Absolutely, but to think that there's going to be one medication is not really the issue. Choosing the target is really the hard part. Where do we want to focus our attention? If you happen to be in the Thai military like this guy, holding the target, that may not be the best job in the world. But if we can figure out where to address this, a lot of interest and excitement with stem cells. Stem cells sort of permeate everything from syringomyelia to traumatic brain injury. And the reality is with stem cells, I think we're not quite there yet. We don't really have a good enough understanding of how stem cells work in each environment. So to think that you're going to inject stem cells in the spinal cord injury once again and have everything be happy is not the case. There is a word of caution. This was a patient from several years ago who went to a foreign country, had stem cells implanted in her spinal cord, so if it's not bad enough to have a spinal cord injury, this young woman developed a tumor in her spinal cord from stem cells which transformed into a malignant tumor. So we do need to be very careful. We don't want to take a benign, non-malignant process like spinal cord injury and give you cancer. That's not good. It's always with some caution. So I started thinking about the blood supply of the spinal cord as we go back to Brieg and others and cerebrospinal fluid. What can we do differently for acute spinal cord injury? Something maybe that we've never done before. When you look at spinal cord blood flow, just as we look at blood flow in the brain when you have a traumatic brain injury, after the injury we have a decrease in blood flow to that area of the brain. And when the blood supply to the brain goes low enough, what happens? We fall into a coma. Well, if the blood supply goes low enough in the spinal cord, we end up losing function there too. And the reality is that this is fairly predictable over a course of what we call autoregulation, which is the spinal cord's ability to perfuse itself over a wide variety of pressure. So if your blood pressure drops a little bit, your spinal cord is still perfused, your brain is perfused. If your blood pressure goes high, again it's perfused. But that is lost with spinal cord injury. So when we have a spinal cord injury, the autoregulation, the spinal cord's ability to maintain blood supply is altered. Part of that's from the direct trauma. So when we look at this autoregulation, again, it's fairly constant over a range of arterial pressure and a range of CO2, just like in the brain. If you drop somebody's blood pressure low enough, they're going to faint. If you drop spinal cord blood pressure low enough, pressure of the spinal cord, you'll have spinal cord infarction and you'll have a spinal cord injury. So we looked at this. This has been looked at over the past 50 years, and it really mirrors the brain about what happens. And when you have a control group, you've got beautiful autoregulation. With a moderate spinal cord injury, there's a dissociation. Those curves diverge because the spinal cord loses its ability to maintain the blood pressure as it should, and that happens with the trauma. When you have a severe spinal cord injury, they're completely uncoupled. And what that means is that the spinal cord has no ability to help perfuse itself. That has to be done. So for years in taking care of brain injured patients and spinal cord injured patients, the kiss of death was low blood pressure or hypoxia. When patients would come in with acute trauma who were hypoxic and or hypotensive, they uniformly would not do as well. I would look at the run sheet from the paramedics when patients would come in, and when you'd see somebody who came in with a very, very low blood pressure and a low oxygen concentration, those patients uniformly did poorly. And the same goes with the spinal cord. And again, we know what happens when you've got a low blood flow to the spinal cord, then you've got infarction, you get all these terrible things that happen, and make that spinal cord injury worse. So again, when you've got a local injury, you have hypoperfusion of the spinal cord. What's affected? Well, interestingly enough, the gray matter is affected more. Why? It's deeper. Those cell bodies need more oxygen. So those are those cell bodies, the motor cell bodies, etc. When you've got decreased blood supply, they're the most affected. The white matter tracts are relatively spared. You can get hyperperfusion as well, and part of the problem is regulating that blood pressure after an injury. So a lot of things happen, and that all depend on where in the spinal cord when you have an injury. So is it the cervical spine, thoracic spine, you've got intercostal, sympathetics. So we get spinal shock, and we then get a response, blood pressure response to that. And that's the body's trying to help, but when you have that area injured and you can't mount that response, you'll get bradycardia, you get hypotension, and that's not good. And then ultimately, when these things happen, you've got death of neural tissue. So what we want to do, obviously, is avoid that bradycardia and the hypotension in these patients. So that sort of started this whole realm of thinking about perfusion pressure. We want to increase the blood pressure. So we know that to increase that blood pressure is a good thing. So we want to keep the blood pressure up, because I told you that when it's low, it's really bad. And by sustaining it in an elevated fashion, we know that we can we feel better about perfusing the spinal cord, because once that autoregulation is gone, that doesn't happen. There have been a number of studies done, all class 3, not randomized studies, because we're not going to randomize you to being in the low blood pressure group. Everybody got the blood pressure. But when we looked at this, and fairly thoughtfully, we realized that those patients who do have low blood pressure, who were treated outside of the study, they didn't do very well. The patients who were treated with aggressive blood pressure management, where we kept the mean arterial pressure above 80, they tend to have better outcomes and better neurologic recovery, and that's been shown in multiple studies. I was part of the guidelines authorship for spinal cord injury, and that was one of the recommendations. Again, it's level 3 evidence. This isn't randomized prospective data, but we know on a whole bunch of data, research and empirical data shows that low blood pressure is bad. We want to keep it up. We do this in the brain, right? We treat brain injury by treating the CPP, cerebral perfusion pressure. So we take the mean arterial pressure and we take away the intracranial pressure, and that's the CPP, and we have a target range. We don't do that in the spinal cord. And why is that? Because we don't measure the pressure in the spinal cord. So I would argue that we're sort of losing an opportunity here to treat patients effectively because we're not measuring that. In the brain, we have to drill a hole in your head and stick a catheter in your ventricle to measure that pressure. In the spine, we can put in something called a lumbar drain, very easily done, to measure that pressure, but it's not done routinely. So the question I started thinking about is, why is that the case? And what can we do with these variations in blood pressure? How can we help those patients? And again, this has to do with cerebrospinal fluid pathophysiology, which again I think has a take-home message, certainly for Syringomyelia and Chiari when we talk about CSF. So again, I told you the spinal cord perfusion pressure is the mean arterial pressure minus the CSF pressure. What happens? You have increased cerebrospinal fluid pressure, and then all these things happen. You have decreased venous compression, and on down the line to blood flow loss. So interestingly enough, I took the cue from our colleagues in thoracic surgery. So a number of years ago, when the thoracic surgeons would cross-clamp the aorta, predictably about 40% of the patients, I should say, would end up with paraplegia. Think about that. You cross-clamp the aorta for 45 minutes, 40% are ending up paralyzed. Now, you'd say, wow, that's terrible, and it is terrible. The alternative is death, because you were dealing with the aorta in a ruptured abdominal aortic aneurysm. That's a uniformly fatal disease. Vascular surgeons would come in, put these big clamps on, repair it, and pray that the patient wouldn't become paralyzed. So along the way, they did a number of things. They did angiography, they looked at pulse pressures, they started hypothermia, they started reattaching intercostal vessels. They did all these things here on the left to try to stem that tide of paraplegia that occurred with us. And I just remember seeing some of these patients while I was in training. It's awful. These are sick patients who come in, go through a surgery, and then wake up paraplegic. Well, the good news is you lived through the procedure. Unfortunately, you're now paralyzed. And that was a very tough pill to swallow. The thoracic surgeons did a great job, and this number has really now fallen down to 4% for a number of reasons. Probably the biggest reason is that they're faster. They don't have to cross-clamp the aorta for 45 minutes. The second reason has to do with nothing with surgery at all. It's endovascular therapy, which obviates the need of cross-clamping the aorta at all. But along the way, they stumbled upon CSF drainage. And there was a couple of studies that were very beautiful. When you cross-clamp the aorta, what happens is you start getting an increased intraspinal pressure, okay? The cerebrospinal fluid pressure increases. When that started increasing, that does so at the expense of blood supply to the spinal cord. And these animals were getting paralyzed. So that's what was happening. Well, it was one of the reasons. So Bauer here in 1989 and a couple others did some studies where they put a lumbar drain in, clamped the aorta, pressure would go up, they'd drain spinal fluid, and those animals didn't become paralyzed. So it was that pressure head of spinal fluid itself. Spinal fluid, which we know protects the brain and spinal cord, which is bathed in spinal fluid. How can that be a bad thing? Well, it's a bad thing when that pressure becomes a problem. So this was repeated in rabbits. I did this experiment about 10 years ago in rabbits as well. We looked at this, and again, draining spinal fluid, very powerful, preserving tissue and function in animals. So we wanted to look at this. We did this experiment in large animals. It had been done in smaller animals. Very difficult to work with. We chose swine model, much easier to work with. Large pigs. We did a weight drop onto the spinal cord. We started monitoring all these parameters. And here's what happens. When you have a spinal cord injury, what did I tell you? The spinal cord blood flow drops immediately. Intrathecal pressure stays constant. So what do we do to treat these patients? If the patient comes in with spinal cord injury, we increase their blood pressure. That's what we do. So we start giving them Levophed, increasing their blood pressure, and guess what happens? Their blood pressure goes up, and the intrathecal pressure starts going up. Well, when the intrathecal pressure starts going up, something bad happens. And what that bad is, when we started measuring blood supply to the spinal cord, he realized that the blood supply was down. As the intrathecal pressure went up, the blood supply to the spinal cord went down. When you open the lumbar drain, look what happens. The blood flow goes up to the spinal cord. You take away that pressure head, you take away that fluid. So we're increasing your blood pressure by giving you medication. We're opening the lumbar drain, and your perfusion of your spinal cord improves. So something as easy as putting in a drain, and this was just absolutely beautiful representation of what happens. Have a spinal cord injury, we start increasing your mean arterial pressure, your intrathecal pressure goes up. Here I should say, your blood flow goes up, and then it starts going down. You open up that drain, and immediately the perfusion starts to improve. And this is the final take home of that, which is this. It's not just good enough to increase the blood pressure. You've got to drain spinal fluid, and this is spinal cord blood flow at a percentage. These are the animals that had. All the animals had spinal cord injury. Had spinal cord injury with increasing the blood pressure and draining spinal fluid. You had sustained perfusion of the spinal cord. If you just increase the blood pressure, it works for a while, and then look what happens. If you just drain spinal fluid, it doesn't work. You have to do those two things together. So you're thinking to yourself, well, why aren't we doing that? Well, I thought that same thing, and we started a multi-center trial, which is now ongoing. Today, I just got a text message in the afternoon. We just enrolled the 7th or 8th patient in the study. This is a Department of Defense sponsored study. And why did the Department of Defense choose to sponsor my study? Because this is something that can be applied anywhere in the world. It's not stem cells. It's not a medication. It doesn't require anything special. Put a lumbar drain in, and a patient has a spinal cord injury, and drain that spinal fluid. This is one of the first patients, an individual who fell from a ladder, had acute spinal cord injury with compression. Ultimately, the patient had surgery, had the lumbar drainage. He's not in the control group. He's in the active treatment group. We're going to have to wait to see the results, but there's no doubt that certainly all the animal data suggests that there's an increased improvement in perfusion. Hopefully that will translate to improved neurologic function, because if that's the case, then there's something we can do that doesn't cost $1 million. There's something we can do in theater for our soldiers and airmen overseas who are involved in battle-related injuries, something we can do to prevent this and improve their outcomes. So, final word about cerebrospinal fluid. Again, we focus on Chiari, we focus on Syringomyelia, but I would argue that some things might be lost upon us. So this is a beautiful article that came out about a year ago from Princeton, where they had a zebrafish model of scoliosis. Okay, and I said, well, how do you give a fish scoliosis? And it turns out when you take away this mutation in this one protein kinase, you start getting this scoliosis in a fish. And I think the reality is that what it turns out is that this protein codes for cilia within the central canal of the spinal cord. And interestingly enough, when that is knocked out and you don't have that cilia, and you don't have that normal pulsation of spinal fluid through the central canal, the fish becomes scoliotic. Why does my 13-year-old niece develop scoliosis? The orthopedic surgeon who operated on her in Los Angeles doesn't know. Nobody knows. Wouldn't it be interesting, and isn't it bear further thought, that if there is some problem with CSF flow and we can change that, imagine if the patient could be shunted or we do some sort of cerebrospinal fluid diversion, something that we could treat scoliosis without having to put screws and rods in people's back. That's where this whole thing comes full circle. That's where the Chiari Foundation has really at the forefront of our understanding and helping us as surgeons and scientists understand the pathophysiology of this disease. Because again, it's not just Chiari or Syringomyelia or spinal cord injury. All these things are interrelated, and I think the time is now for us to be able to look at this, expand our horizons, and think about things like this. So, and how that might all relate, especially in a higher end, aspect of basic science where it meets the pathophysiology of Syringomyelia and Chiari. When it comes to spinal cord injury, my final word is always about prevention. For years, I've been part of Think First, which is a national prevention organization for spinal cord injury and brain injury. So we should always, obviously, would love to prevent those injuries. And with that, I'd like to conclude my remarks and thank you all for braving the streets of Baltimore to join us. And appreciate everybody coming here, and certainly will answer any questions if you have any. Thank you.
We'll take any comments or questions from the audience. We also, I believe, have the ability to answer any questions that may come up now on the WebEx, and also may get questions in the future as people see this on the web pages.
Dan from Indiana, please, your question. Okay, sorry.
Dan, yes. Dan's not coming through. Let me start with a comment you had in the beginning of the talk. You talked about flexion extension, and you showed how stretching and kinking can occur just with simple flexion extension.
Right.
As you know, in Chiari malformation, some people postulate that it's not always compression, but it's an acute angle in the brainstem over the clival-axial angle, which is causing this, and perhaps increased motion in that area might be causing more flexion extension. Do you see that as a possible mechanism besides compression, or is it
100%? So, when you look at patients who have a decreased clival-axial angle and you have more of a platybasia, for instance, there is a draping of the brainstem, right? And that changes everything, because first of all, that's not necessarily normal from a physiologic standpoint when it comes to motion. And then secondly, what we don't know, and I've not heard anybody look at exactly what happens to the brainstem, but we see on MRIs, on flexion extension MRI scans, in those patients who have platybasia or have some abnormal clivo-axial angle, that may lead to more stretch. And again, that also fits into what I've been talking about here, which is how that increased stretch leads into pathophysiologic conditions. So yes, I do think there's something that's a related condition as well. Absolutely.
You also, if I can ask just a follow-up, which is not really a follow-up. But you mentioned the CSF flow issues. Of course, I'm interested in that from the perspective.
I saw you taking notes, Dr. Luciano.
Yeah, I was actually drawing. You're drawing. We've felt about the cilia, especially in the aqueduct, maybe keeping that area clear and stopping obstructive hydrocephalus. We often think of Syringomyelia in some ways perhaps as a hydrocephalus of the spinal cord. So the idea that keeping that channel open,
right.
But often in adults it's closed in any case,
right.
We know that. But that's an intriguing possibility. But there's also the idea of that fluid, obviously, that's drained out from the outside of the spinal cord. In Chiari, we have the vision of the pistons pushing down, an abnormal disequilibrium of CSF between the spinal cord and the cranium. So it makes a lot of sense for fluid to be affecting blood flow. I mean, that makes a lot of sense both in the CSF
right.
and the spinal cord. But my question is, in terms of the syrinx, we associate syrinxes at or above or below the level of obstruction in CSF flow.
Right.
And trying to think about pathophysiological mechanisms, would you envision the possibility that increased CSF flow above an obstruction is causing a blood flow in part of the spinal cord and not the part below, and so forth?
That's a great question. So, I mean, this goes back 20 years, and I remember being at the NIH with Ed Oldfield, who was doing some of the seminal work in that at the time, when we were literally putting in ventriculostomies, lumbar drains in Chiari patients, trying to measure that pressure gradient and that differential. There's definitely something to that. I absolutely agree. What's the threshold? Is it there in every patient? I don't know if we know the answer to that. And the other issue is fixing the primary problem. So for Chiari, if we can expand the posterior fossa to take that away, is that a cure-all, or are we still missing something? That's a great question. I don't know the answer to that.
A possibility. My final question is when you do shorten the people, do you offer them like high heels? Or any supplement?
Tailoring. The pants get hemmed, and we're all set. So, well, thank you very much, everybody. If there are any other questions, you can get them to Dorothy at the. Oh, yes. No, go ahead.
Well, I'm intrigued. We've been looking at the older work by Breed and working with some physical therapists on a completely non-surgical problem, and that is chronic fatigue syndrome.
Sure.
We find that these patients are very tight when we put them in positions of neural strain. We can reproduce a lot of autonomic symptoms, fatigue, and brain fog when we do a straight leg raise that we sustain at midway between the onset of stretch and end range. So they're getting these kinds of changes,
right,
but without the surgical changes. It's fascinating.
So the whole neurodynamic, tension field. The part of the problem is, to that point exactly, is it's not well studied rigorously. And where we lose the thing, and that's why, unfortunately, Briggs' work has been adopted by chiropractors. I've got nothing against chiropractors, but the reality is that the science behind it, sort of lagged behind. I 100% believe he was on target, and there's definitely subtle stretch that leads to PEP. I mean, I take care of patients with spinal cord problems every day, and I will tell you that 100% there's something to that subtle myelopathy, and quantifying and qualitating that is very difficult to do. But to your point, absolutely. My hope is that we can study that in a more rigorous fashion so that we can bring that, because there's a bit of a disconnect in what's become folklore and what's science and what's not, and that's part of the problem. But I've seen that work from NDS and others, and I do believe that there's something to that. I agree. Thank you.